I'm wanting to really give a first shout out to Chris Shipton. He's with us again. He's got a company called liveillustration.co.uk, live illustration, all one word. We love his illustrations, and we're so glad that he's here to capture our discussion. I'm very, very pleased to see many familiar colleagues and friends on this. And as is the usual case, now it's become a bit of a habit. Hello, Chris. I've decided that this, the Tuesday briefing, I'd like to give my update on the status of the epidemic. And I also want to go to a number of countries around the world just to give you accounts of what's going on. The characteristic of our briefings in the 4SD Open Online Briefing series is we tell it like it is. We do everything we can not to sugarcoat, but at the same time, we don't want to be overly despondent and gloomy. We want to find the points of excitement and promise, as well as the points of concern. We will today pay particular attention to challenges in India, challenges in Mexico, and also challenges in the United States and in Western Europe. And that's because we do have to stress to you that the epidemic curve continues to accelerate. Now, what do I mean by that? Well, I mean that the number of people newly reported with the disease is increasing day by day. We saw a plateau in the number of new cases during the period late April and early May. But in the second half of May and into June, the numbers are accelerating and the rate of acceleration is increasing. And that's simply reported cases. What I need to add is that we also are well aware that the number of reported cases is well below the actual number of cases of COVID-19. The numbers of deaths continues to grow. 500,000 people dying as a result of this disease, 10 million reported cases. And the deaths are increasing. And we also know that not all the people who die as a result of COVID are being reported as COVID deaths. In no way is this turning out to be easier for poor countries. Instead, we're seeing overloaded health systems all over the world. And it's happening simultaneously, whether we're in Pakistan or in India or in South Africa or Brazil or Mexico, or indeed in parts of the Middle East. Health systems are getting overloaded, not everywhere. And this is what I have to keep reminding everybody. This is not a universal phenomenon because each outbreak of the disease starts local and builds up in a very focal way. So it doesn't mean that the virus is absolutely everywhere. It means that the virus is found in different countries, but it's with very local spread. So just yesterday, Tedros, the Director General of WHO, commenting on 6 months of the pandemic, said the worst is yet to come. And I thought I'd explain to you why he's saying that. First of all, he says there's a lot more people going to get this virus, particularly in poor countries. Secondly, he says this virus hasn't changed and is going on spreading, and we see it very much in North America, and particularly in the parts of the US, where we've got really rapidly increasing rates of COVID, particularly in Arizona, Montana, Florida, and Texas. And then in Western Europe, where as a result of a Herculean effort, numbers of cases reduced, now it's picking up again, with isolated outbreaks being picked up, just a few of them so far, but we know that the number will increase. So I'm saying to everybody, anticipate a really difficult next 6 months. a real roller coaster ride around the world, with numbers of cases on the increase, health services of poor countries stretched, really high levels of death and suffering among poor people everywhere. And I'm afraid real challenges with the restarting of economies in advanced nations that thought that this was just going to be a straightforward process. And it goes back to what I've said before. There are three things that are absolutely vital. The first is that people everywhere need to just make sense of the reality of this virus and be ready to adapt their behavior so as to reduce the risk of transmission. Physical distancing, face protection using masks, hygiene, hand hygiene and cough hygiene, isolating yourself if you've got symptoms of disease, and making certain that those who are at highest risk are shielded as much as possible. Now, this sense-making process of individuals is happening everywhere, and I know that there are at times upsets from people saying there are lots of people on the beach or there are lots of people gathering and they're not respecting physical distancing, but that's okay. That's because for many people, they haven't yet found a way to make sense of it. And over time, we will see the sense-making occur. We will see more respect being given to physical distancing. I suppose my plea and my advocacy is that those who are responsible for the conditions under which people work and live should do everything they can to make sure that physical distancing, face protection, and being able to avoid working if you've got symptoms of disease are built into employment practices everywhere, and that they become the norm rather than just the few exceptional employers who really are obeying best practice. I don't want to go on seeing owners of meat factories saying that if they create safe working conditions for their employees, that's going to mean that they can't stay in business. I'm saying put your employees' health number one. And if that means that you've got to change your business practices, so be it. I'm saying to those who run public transport, put your employees' health number one. And if that means you're going to have fewer people on your buses, on your airplanes, so be it. I'm saying to people who organize the migrant worker dormitories around the world, whether they're in Europe for agricultural workers or in the Middle East for construction workers, I'm saying put your workers' health number one. And if that means that you have to charge more when you bring in a gang of workers from across the world to help provide cheap labor, then so be it. You've got to charge more for your laborers. You know, we've got to stop having a situation where poor people are required to put their health at risk for the sake of getting cheap produce or cheap transport, and then that benefits us, no doubt, but it's really terrible for them. And I keep saying to those who want to go to beaches and play around, fine if you're out in the open and actually respecting some physical distancing protocols, but think of the people who clean your toilets, who serve you in shops, who park your cars, or who drive transport, the bus that takes you to the seaside. They're the ones who are being put at risk. So I'm continuing to make the point that inequity in exposure is key. I'm also stressing when we go on talking about the situation of dealing with COVID, that we've got to start looking at the places where people live and just changing the characteristics of those places so that they are less places where COVID is easy to transmit. So what am I talking about? Well, I am talking about prisons. I'm talking about detention facilities. I'm talking about residential care for older people, for disabled people. I'm talking all the time about places where poor people are put to stay, and that's where migrant worker accommodation is so important. Talking about settlements where poor people live in Indian subcontinent or in Africa or Latin America or the Middle East. All the time saying we have to make sure that working conditions are conducive to avoiding COVID and that living conditions are conducive to avoiding COVID. So I'm focusing on people making sense of the virus, people being enabled to protect themselves against the virus, people being able to live in conditions where they don't get the virus. Because I'm recognizing that as this virus continues to advance across the world, it is going to be poor people, how they live, where they live, that's going to be the important determinant of whether or not humanity is able to get ahead of it. Now, in order to make that possible, we've got to have basic public health services in communities that actually do touch people and that people know about, not privatized and run by some agency that's miles away, just available on the end of a telephone, but neighborhood health watches, local community health organization, the kind of approach to public health that we always advocated, those of us who were working in development. We used it. That's how maternal and child health services built up. You know, let's keep that spirit that we worked on in our health facilities, in our work globally, and make certain that that's dominant. And promote that in advanced nations who've given up on community-based public health. That's absolutely critical. Every one of you, I'd like you to please be advocates for community-based healthcare. Without that, it's going to be really hard to keep COVID at bay. Without people knowing who is their local health sentinel, who is the person they ring up if they're feeling ill, who is the person they get help from. Is it the general practitioner? Well, if so, let's make sure that GPs are organized so that they're covering the population. Is it the village health worker? Okay, let's make sure that the village health workers are properly supported. Or is it the community health volunteer? If so, let's make sure she, because it's usually a woman, is adequately resourced and is properly supported as well. Getting that honeycomb of community-based public health is absolutely key. I have not done well enough in getting that point out in my advocacy over the last few months. I've talked about it in the earlier briefings, and I feel that I now need to be stronger on it. So if testing, tracing, and isolating is to be at the heart of being able to interrupt transmission and prevent COVID from becoming enhanced, if testing, tracing, and isolating is key to ensuring that there's access to other forms of healthcare, like reproductive healthcare, like child healthcare, like healthcare for dealing with chronic diseases, then we have to make absolutely certain that testing, tracing, and isolating is prioritized by governments everywhere. And it keeps slipping off the agenda. People say, oh, well, we can't do it well enough. Contact tracing isn't working. I've heard economists recently saying, why bother with contact tracing? Answer, because all the evidence suggests that if you want to interrupt transmission early, stop clusters from developing, and make certain that you don't have outbreaks of this disease, as well as identifying people with the disease and isolating them, you must do the contact tracing. That's the heart of stopping outbreaks from developing. So part one is people change their behavior. Part two is that societies are able to interrupt transmission. And part three is that when you do get an outbreak, like what is happening in Leicester, England right now, you suppress that outbreak really fast, decisively well. Now, of course, there are people in the UK arguing, saying, oh, well, we don't know what powers we've got and nobody told us that we've got a problem in Leicester. But it's absolutely essential that as work is advanced, we will get much greater, seamless, automatic activation of local authorities to be able to get on top of, suppress outbreaks really quickly, to do it in a nice, dignified way, to make certain that people's sensitivities are attended to, but to make the point that for 2 weeks, there is going to be a stop on movement in and around the area where there's an outbreak. That's the only way you can get rid of it. And if we can't have these habits of, number one, people changing their behavior, number two, the capacity to interrupt transmission in all societies, number three, the ability to suppress outbreaks when they build up really quickly and robustly. We can't have that capacity everywhere. This virus is going to defeat humanity. And I am saying this more and more strongly. Part of my anxiety, as some of you know if you tuned in last week, was that I was beating myself a bit for failing to make the point strongly enough that this work needs everybody working together to a standard message. I was beating myself because I hadn't really managed to get that across strongly enough in the UN, in the WHO, and in the different organizations we work for. So now I am utterly committed to strenuous, constant advocacy with all of you and beyond to get the message out. This is a simultaneous, all of humanity behavior change challenge to reduce the risk of spread of this pathogen that is primarily a respiratory pathogen. Secondly, it requires a capacity in every community right throughout the world to interrupt transmission. Thirdly, when outbreaks develop, they've got to be suppressed fast. And overall, poor people are suffering the most as a result of this disease. Poor people who are not in strong employment situations, who don't have resources to spare to be able to cope with their challenges of being able to be without food for a period of time or without income for a period of time. It is poor people in poor places who are mostly at risk. And we have to collectively deal with this. So that I'm increasing my political advocacy, increasing my media work, and increasing my engagement with world leaders everywhere, saying this hasn't gone away. It is advancing in poor countries. It is affecting poor people. Deal with it by focusing on people, focusing on public health, and focusing on the ability to deal with outbreaks as they come. Let me just give you just 2 or 3 little vignettes before I move on to your news. My friend Joe Nichols, who worked with me on Ebola, sent me a note from picking up a telephone phone-in show or chat show in Somalia. What are people concerned about? Well, they're concerned about very similar to what they're concerned about in the UK or what they're concerned about in India. How do you differentiate COVID from flu? How do you be sure that your neighbours really are taking their sickness seriously and are not sticking around at home and infecting others? Is vomiting a symptom of COVID-19? Can COVID-19 be confused with malaria? Can you get COVID-19 more than once? Are there differences in religious perceptions of COVID between, for example, Muslims and Christians? What can communities do, especially if the government is not strong at local level? And are face coverings really effective? These are callers into a radio chat show in Somalia. And what I'm encouraging is that same opportunity for people all over the world to be able to have dialogue about what COVID means. I'd like to be responsible for a global dialogue about COVID everywhere because I think it is so important. Argentina, let's go to the Southern Hemisphere. What's happening in Argentina? They're really worried with the winter setting in. I think most people perceive that in cold winter weather, COVID is nastier. It's also going to have to be differentiated from other respiratory pathogens. So in Argentina, they felt really good because early on, their incidence rates were really low. They had a super tough lockdown, but they've had to release their lockdown because it was having such enormous economic consequences. And they are trying to cope with the fact that they know they're going to get an increase in numbers of cases. Switzerland, let's go to Zurich. What's happened in Zurich? Some of you may know. They've recently had a problem because there was a nightclub in Zurich where all the staff got COVID and some of the clients, a lot of the staff got COVID and the clients got COVID. Basically, they've had to send all the staff home and they've basically been required to recruit a whole new set of staff to reopen the nightclub. So we are just dealing in Switzerland, we're seeing the return of COVID, as I'm calling it. And it's not just the only country. In China, they've got virus come back in Beijing, and they've done a huge testing regime. they've basically been trying to test something like 8 million people for COVID. They're trying to find out where the virus is in Beijing. They're really worried that it's widespread. They want to get on top of it. And I mean, we have to take our hats off to the Chinese, just like we did when they closed things down so quickly in Wuhan at the beginning. This incredible situation where they basically got testing capacity of 450,000 samples a day. And that's how they've been able to do samples from 8 million people in Beijing. And that was in a situation where they had 318 cases detected stemmed from a wholesale food market. So this is the effort by the Chinese to really get ahead of their COVID. There are not many parts of the world that have the capacity to do this. We go to South Africa. Western Cape was where the epicenter was in South Africa. It's now in the Eastern Cape. And it's particularly disturbing. It's spreading wide. They have not got the testing capacity to really get ahead of it and get on top of it. They're somewhat behind the number of cases. The situation in Eastern Cape is quite disturbing. It's a relatively poor area. There is a shortage of hospitals and a big anxiety on what this is going to do, because the country did have to release the lockdown so that they were able to deal with the economic consequences, but the virus is spreading and hospitals are getting full. If we look at other countries, perhaps the 2 or 3 that I'd really like to pick up on: Indonesia, very large country, very large number of cases, basically one of the worst hit nations in Southeast Asia, and they've had to increase testing. Now you might say, well, isn't there really a disadvantage? The more you test, the more cases you find. But if you don't test, you don't know where the virus is. And if you don't know where the virus is, it's really hard for government and people to get on top of it. And India, I'm really impressed by what's happened in Mumbai, in Maharashtra. There they had really big problems in Dharavi slum, and the figures seem to be just increasing and increasing and increasing. But as a result of really good contact tracing by some incredibly dedicated health personnel, and it was a tough task by the authorities. It looks as though the Mumbai situation is improving, but now the epicenter of the outbreak in India is Delhi, with something like 80,000 people infected, and a number of deaths. It's not as high as we're seeing in other parts of the world, but nearly 3,000 deaths recorded, and I suspect probably more people dying. So it's very, very serious, and friends of mine who are in Delhi are saying this is a particularly challenging situation. In Chile, the situation is primarily in Santiago. It's in poorer communities in the city of Santiago. Localized lockdown has been very much needed. Let's go to Mexico. The president is called Andrés Manuel López Obrador, or AMLO. He says the virus is not important. He's encouraged people to keep going out, to keep embracing and hugging, despite the fact that his deputy minister of health, a famous guy called Hugo López-Gatell, has been asking people to stay home. So you've got a difference of opinion between the president and the deputy ministry of health. And they're really worried about what's happening in Mexico. If you look at the numbers in Mexico from different people, they're basically seeing, first of all, that there is an awfully high positivity level in their testing, which means they've probably got many more cases than they're picking up through testing. There is a situation where the level of economic support to people who are affected by COVID is quite limited. And there is a quite severe set of economic tensions in the country. Mexico isn't the only country in this situation, also Brazil, also Venezuela, and 1 or 2 other countries as well in Latin America, and in Africa, and in Southeast Asia. What I'm just trying to say to you is that where you've got a difference of opinion within the country between different leaders, it can create instability. Where there is instability, this could well lead to political challenges. The situation in Mexico at the moment, particularly among poor Mexicans, and the current tension between the president and others in government make this a very delicate situation indeed. Information about this has come from one of our colleagues who connects with us quite regularly. I'm very grateful for that. I think we must be really realistic now. There are some countries that are dealing with this challenge remarkably well. There are others who are facing all sorts of difficulties. I think it's our job, those of you who join us in these meetings and those of us who are active internationally, just to continue making the point. This is a major ongoing challenge for the world. It's set to advance in a continuous way over the next 6 months to 1 year. It should not be trivialized, and it must be dealt with through the collective effort by people, by public health services, and by the whole of government. Otherwise, it becomes an impossibly difficult situation, especially for poor people. Right, I hope that's okay. As I say, not sugarcoating. I'm sitting here with Florence, and she is showing me some of the information that's coming through from different people. Most grateful to you for sending in comments. If at any point you want me to show you the latest WHO figures, I could do so. I want to say that they are like what we had last time, showing an acceleration. It's just the acceleration really is picking up right now. And for me, that is a major challenge because an acceleration that's speeding up, basically that does not get easier over time. And it is this rapid acceleration that I'm trying to get everybody to be aware of. See if I can quickly just do this because I want, there we go. Yeah. I'd just like you to see, if I can do it now, yeah. If you've got this in front of you and if you can see what I'm seeing, I have drawn this red line as an effort to demonstrate what we believe to be the moving average for new cases. This time last week, we were about here. We weren't quite sure whether these two high bars were anomalies, but the general pattern is, as I've shown here, a really important thing is to demonstrate this acceleration that's going on. Now, this is based just on reported numbers. And of course, the Africa figures, which are the ones up the top, they're relatively small compared with the totality. Look at the fact that the death line here, it's not accelerating at the same rate. It's beginning to do an uptick overall, but basically there is not a suggestion here that the, oh yeah, so now what's happened? There's not a suggestion there that the rest of the world is somehow being let off. It is, you know, this is a serious looking death figure. It oscillates a bit. And the big numbers are coming in the yellow bars, which is the Americas, and the blue bars, which is Southeast Asia. We're waiting to see what happens here in Europe, the orange bars, and the purple bars are the Middle East, which is staying just about stable. I worry about this gradient. I don't like it at all. Okay, so now on to your comments and questions. I'll stop sharing my screen. We'd like to look at Chris Shipton's illustration. Can we get Chris's thing to come up big? Let's see if we can. I can do it on mine. But if you can see Chris's figure, let's see if it comes up. Why do I want you to see Chris's figure? Because he is showing us some of the things that are particularly important. Chris, if you could shout out, it may be take your mute off, if that may be what's, thank you, to get your picture big.
Oh yeah, I think I need to be spotlit.
That's done, it's come.
By whoever's in charge of spotlighting.
Yeah, it's done.
Okay.
Do you want to tell us anything, Chris, about what you feel like as you're doing this illustration? It looks absolutely brilliant. Just give us.
Oh, I mean, you know, I'm here as a concerned citizen, and you know, it's very interesting to hear the global perspective, because I'm just a sort of, you know, sitting here in England worrying about Leicester, and you know, you just don't hear about the rest of the world. So you know, it is I don't know, galling to them, but hopefully this image will help people who see it, you know, get the message.
The only thing I would say is that in not all the countries where we work are the hospitals looking quite like that big 20-story building in your thing. They are in some places, and actually if we were to look at health systems in Sao Paulo or in Mexico City or other the cities that are affected, indeed, they would look a bit like that. Thank you very much indeed for Chris for doing this. And we're very, very nice of you to put it out. Just like to say that in our team is Twee Nguyen, who's our communications person and who maintains the liaison with Chris and also organises these sessions. Catherine Deland, our health advisor, who should be visible on the screen. John Atkinson, who's not here today, but he normally is, so I won't call on him. Julien Delamontex, who is looking after a particular part near France and is telling us what's going on in his place. My brother, William Nabarro, who's helping us a lot on some of our work with businesses. Magali Mahdi, working on our relationship with civil society, our scheduling. Florence Lasben, who is our managing director and is helping me with particularly bringing in your comments. As usual, I'd like to try to give you a chance to have an opportunity to speak. But the first question, I think I will just talk about it and then we'll go to others. But also I want to just say that I'm recognizing people on this briefing who've not been on previous briefings. What we usually do is we do give people a chance to pop in and speak briefly if they want. You just have to tell us by sending us a message. We like to know who wants to speak so that we don't bring people in without them being warned. Just to say that I'm delighted that we've got people from all over the world, to Rojan joining from Kathmandu, and I'm very keen that we have another of our check-ins shortly, Rojan. I've got things that I'd like to discuss with you, and there are things that I know you want to discuss with me. I'd like to say that we have also got people from the US. Chris Lara, thank you for joining from Duke University, and we're grateful that you're with us. And Sally Smith, thank you for joining again. I think that the work that you've been doing in bringing faith groups in, especially given that this is now such an inequity issue, is absolutely vital. And I've followed up on some of the points you made after our last session with several people. Sally, I'll give you, going to comment on some of the points you've made. I'd like to just say real greeting to Robin Gorner. Robin, the movement now of people who've had debilitating illness as a result of their COVID is picking up. I mentioned to you that I've been talking to people in the UK about it, but I've now started a discussion with some global leaders about it, and we're hearing about debilitating illness in many parts of the world. So the work you're doing, and particularly your publications in Daily Maverick, are hugely important. Sanjukta Skarma, thank you for being with us again and joining. Vicky Doyle and Nazim, your anthems are really important and they're picking up. Everything is picking up. The movement to get people aware of what COVID means around the world is growing, but it's up to all of us to sustain that movement. We can't rely on the international institutions or national governments to do it. This is a global sense-making process. And the first question says, you stressed the importance of public health in COVID readiness. What do you think of telemedicine to bring public health to people? A lot of people say to me, well, what about apps? What about new technology? Doesn't that overcome the need for actually people themselves being in contact with each other to spread the message. I'm very clear. Actually, the kind of work we're talking about involves people and contact between people, connections between people. Unless we have these human connections, there's just no way that we can help people through the sense-making process of coming to terms with this new threat. So let's put the human contact number one. And you can do human contact without having to be next to each other. You can do human contact over the telephone. You can do human contact maintaining the 1 to 2 meters distance. But please make the human contact the central feature of this. We don't want this to be social distancing. We want it to be physical distancing, but social inclusion. Thank you very much for that. So telemedicine will help. And telemedicine can be marvelous for dealing with severe illness. We've seen it being used in Angola. We've seen it being used in the north of Canada. We've seen it being used in Côte d'Ivoire, seeing it being used in Ile-de-France, in Paris. And it's wonderful, but make sure that it is people contact and it's responding to people in a really visceral and emotional sense. People need connection right now more than ever. Sihaj Sharma from Bangalore. Sihaj, I'm looking for you. Can you unmute yourself and just give us a couple of minutes on the point that you want to make about your, come in, Sihaj. I know that you're into medical devices, so you're someone to talk about this question of the role of applications. Over to you.
So there has been a backlash regarding a lot of these contact tracing applications regarding data security, data privacy, because of which a lot of it is fluff and a lot of it is actually real. And because of all of this, there's a lot of hesitance in the public to download these applications, which in turn is hampering government efforts. So would WHO be sending out some kind of public advocacy for these apps or some kind of guidelines for these apps, telling the public that it's all right, that it's safe, calming the people down so that contact tracing methodologies are better put in place?
First of all, thank you for making the point. There's a certain amount of fluff. Secondly, there is a possibility for these sorts of technologies to be misused. So what the WHO is doing and needs to do more of is making the point that there's a place for apps in supporting contact tracing as well as in supporting diagnosis and treatment. But at the same time, there's a huge obligation on authorities as well as on the developers to really respect privacy of people. There's such huge worry about misuse of technologies for control of the public. Sihaj, do you think they're going to pick up in India or not, given the degree of literacy around IT issues in your country?
So we have a couple of applications. One is the central government sponsored application and the other is the state government sponsored applications. And yes, there is backlash on it regarding data privacy and the amount of data they collect. However, given the central government is quite popular amongst people, a decent number of people are complying with it, but let's see how it rolls.
Thank you very much indeed, Sihaj. Stay close, keep telling us what's going on. And you know,
Definitely.
one of the exciting things about India is the huge variation in what's happening in different parts of the country. I mentioned New Delhi, but you and I both know that there's been real progress in the south, in Kerala, and I think also around where you are.
In Bangalore, it's quite low.
Yeah, you've done really well in Bengaluru.
Yes.
Pronunciation right. Brilliant. Thank you very much indeed.
Thank you.
A colleague writes, do I think that upcoming elections in the US and elsewhere will take the focus of COVID? How can we ensure that as politics get heated, we keep cool heads about the public health crisis? Well, let me just answer with one point that I've been making a bit, and I wonder whether you find this useful. No, this virus is not political. This virus doesn't know anything about politics. What this virus does know is that it can exploit inconsistencies in policies, whether they are between states or between provinces or between local government areas, if you've got inconsistency, this virus has fun. So I want to stress to you that I actually think that forthcoming elections are going to bring much more attention to COVID. They're going to get very nasty. I think in the United States, if you wear a mask, you're considered to be one particular political party. If you don't wear a mask, you're considered to be another. I think it's going to get very messy. But I think at the same time, because that upward curve that I showed you of the pandemic around the world is not going to stop. And it's not going to stop in the US, it's not going to stop in other countries unless we take really extraordinary collective action against the virus. I think that the pandemic will increase, the politics will increase, and it will become very intense indeed. So let's try to make certain that we can contribute to dealing with this pandemic in a way that is not derailed by intense political competition. I think it's going to be hard, but I think it's what we've got to try to do. Sally Smith. Sally, I'd love you to make your remark. I notice what you're saying. I give you the floor to say what you want. In you come.
Thank you, David. And again, thank you for these briefings. I think this is just one of the pieces of information that I've seen floating around in communities more recently. And I just don't understand the science well enough to give a coherent response. And I think it could be important. So one of the questions is that as the virus spreads across the world, is it becoming less virulent as it mutates? Some of the scientific reports I've seen seem to indicate that the reduction in cases and perhaps less deaths may not be so much a result of a mutated, less virulent virus, but more a case of more effective management as we begin to learn about how to manage it both in the control side and in the treatment side. So it will be important to get the messaging right around this one, and it would just be helpful to have a bit more information on that if you're able to give it. Thank you.
The way I respond to that is as follows. The virus does, of course, mutate. All viruses mutate, but by and large, this mutation or characteristic has not led to the emergence of a milder version of COVID. Instead, it's the same nasty virus. It's just that the reason for the slightly different numbers in terms of death is changes in the age structure of the populations. Where you've got older age structure, you get a higher death rates. Number two, there is earlier treatment, and that seems to be improving survival. And number three, perhaps in hot weather, the virus is less easily transmitted and people get a less heavy infectious load, and that in turn may lead to a less severe illness. These are not complete answers to your questions, but the core point that I'm trying to say to everybody is that I've seen nothing to suggest to me that overall this virus is becoming less virulent. Instead, it's circumstantial, the reasons why sometimes the death rates seem to be lower. Sally, I'll follow up with you privately if you would like more on that, because I think this is a very important point. But the base,
Thanks very much.
Still a bad thing. Noah Lee, and after you, Noah, I'll come to Marianne Hazelgrave. Noah, you say you're a student from Colorado. You work with our friend Joe Colombano, and you actually, I'm going to ask Loy Rago to come in as well, Noah, with you, because he's got a similar point. So Noah, would you like to make your point now? And then I go straight to Loy, who's going to make his point. And don't hesitate to make it as a statement rather than as a question, if you would like, Noah. Come in, please.
Sure. Can people see me?
Yes, very good. I can see you well.
All right, fantastic. Thank you for having me on. So my point has to do with multilateralism, how countries are working together in this time with all these countries going on lockdown, and the general rhetoric being, you know,
For the first time ever, we got a sound. Never never had one before, but there's something weird happening with your phone or computer. It's doing crackles rather than words. Do you want to try? Okay. Yeah, that's it. It just doesn't work. So Noah was saying, what can we expect from the prospect of multilateralism? So it seems that countries are becoming more isolated. And I just have to say to everybody, this needs unified global response, period. I say it again and again and again. And we need to say it as a chorus. And we need to say it in the hundreds and the thousands and the millions across the world. And world leaders just have to start paying attention. There is just extraordinary dereliction of responsibility by leaders everywhere, insisting on going it alone. Somehow this sensation that the problem can be dealt with by countries working independently, when it's blindingly obvious that it can't be. I keep saying sooner or later they will realize, and I believe sooner or later they will, but the amount of damage done the longer you wait is just huge, huge, huge. We're just seeing it. Levels of poverty and hunger and malnutrition just rising in front of our eyes. Anyway, so we have to all work for effective multilateralism and unity. Loy, come in and tell us your view on this, please. Loy Rago. See if you can unmute, Loy. Just an unmute, click now. Yeah, now the other.
Okay. Yeah, I've done that. No, only two straight points. One is, I mean, I've written it out over here, but I'll just emphasize certain things. That while collaboration globally is important, we need to work at the regional, national, and national is key, but more importantly at the subnational and absolutely locally. So we need to work at the local level, and the lesson I have learned from this particular disaster is that each local level may be different. What are the risks? What are the strategies to be followed? And who are the agencies we need to work with? They have to be planned locally. So let us refocus our attention on the district, state, and township level. And this is something which we all need to recognize. So this is one point. I've also, so if you have any question, please ask me, because otherwise I want to come back to another point.
I want you to go to your...
So I back to the other point, then you can ask me. I want to show you guys, show everybody this publication. And it's when I first met David, the initiative which he took on towards a safer world.
Yeah.
And I reread the publication recently. It's something that came out in September 2011. And it's been extremely educative to reread it, because it shows us and lays out a clear vision of what are the actions to be taken beyond pandemics. I'm not a health person. I'm more a disaster management person, but I do work with health risks. And it has been a superbly educative experience. And I'm revisiting both in thought and mind and rereading a lot of this. So if it is easily available on site, please put a web link. If it is not, please resurrect the old web link. But I would say there is so much here, and I've been rereading it very carefully, particularly the section on IHR. And I find it very important. And it's in fact, I would feel a little guilty that for the last 10 years, I did not reread it, apart from the wonderful exposure that I got in 2011, in spite of meeting you in 2013-15. So, yeah.
It's such a drag that things disappear if you don't keep them alive and watered. You know, that period when we were working on this between 2005 and 2014 was super important. We had really very, very good support. And the countries that really took that stuff seriously, Lloyd, and they were mostly in Southeast Asia, have done so well. I mean, I'm not going to ascribe
True.
A to B, but I believe you're right that towards the safer word public publications and approach are very relevant to what we're doing now. I also think your point about needing local community organisation collaboration is so important. All the evidence suggests that that's the way you get on top of this. Thank you, Lloyd. Let me just, because I'm realising suddenly we're going to run out of time, I want to go to just very quick comments from 2 or 3 people. Marianne Hazelgrave, thank you for being with us. And could you make your point as strongly as you feel like? Shout it down into the microphone.
Very quickly, we're dealing with a cake which is a certain size. Now, we can't make the cake bigger because politically they won't do it. So what do we do? Because I see that on sexual and reproductive health, for example, things are stepping back and there's not enough money. Now, do you pay for COVID or do you have to, how do you deal with it, balance it out? Thank you.
So Marianne, you've got to do everything together and you've got to, and it is the only way. And I totally agree with you. If money and resources and obviously people are taken away from access to sexual and reproductive health care, or HIV, or malaria, tuberculosis, or non-communicable diseases, to go to COVID, it is a tragedy. And we saw this happen in Ebola in West Africa. So please, we all have to keep focusing on the fact that we're talking about total health and not just COVID specific. And I would like to see COVID-related issues very much folded into the rest. I think it's the only way forward. And please keep an eye back on that. You've said here, given the need to prioritise funding for the honeycomb of public health, please make sure that you don't take resources away from other priorities. Can I just go to Leah Marie Lucas? Leah, did you want to say something? Leah.
Yes, thank you so much, David.
Yeah.
And my video is now on. So I just wanted to sort of reiterate something that Dr. Nabarro shared with us. And, you know, he discussed this as a behavioral change challenge. And what really stood out to me is that there are some of us that have the ability to change our behavior. There are some of us who have the privilege to be able to take steps to put other people at less risk. And these people are other people who are essential workers, as he stated, and also the mention of, you know, prisons, detention centers, migrant workers, etc. This was something that hit home really, really close for me, having worked in prisons in various countries, worked with migrants, with IDPs and refugees. You know, it's a very sombering reality when we think of the impact of COVID on these populations that really have little ability to be able to change their behavior. So I just want to, you know, commend David once more for mentioning these people who really are living at the brink of survival in some cases, and then think to each one of us what we can do in our own lives that may be uncomfortable, but perhaps can protect those who can't protect themselves. So thank you so much, and it's been a pleasure being a part of this.
Thank you, Lou Marie, and thank you for joining us. I'd just like to, there are 1 or 2 others who want to talk about this. Sometimes it's called the bottom billion, sometimes it's called the big divides. Rebecca Cantor, who's joining us, I think, from Chile, and is focusing on Chile. Rebecca, where are you? Are you in Chile?
Yeah, I'm in Santiago, under very tight lockdown. Very tight.
Give us your perspective in a minute from where you are in Santiago.
Well, we keep increasing the restrictions here. So as of about a week ago, 5 online police permissions to get outside went down to 2. So I have a dog, so I can only go on 2 dog walks a week. Luckily, I play the system a little bit and use my passport and get 4 dog walks a week, but that's me talking from a very privileged standpoint. I'll just build off of what Leo was just saying. We have to think about all the other people that don't have the privilege that we have to stay inside, to have digital literacy. I put it in the chat multiple times, but I'll just keep saying it, that I think the digital literacy divide is just going to continue to increase. during the COVID ready state if we don't do something to address it, especially in poor areas that also might have now technology, smartphones. In Chile, there's more than one smartphone per 100 people, according to the World Bank. But there's still not full Wi-Fi internet connection, cellular signal in the whole country. But again, on top of that, it's digital literacy. Digital literacy, don't forget it. We're all, again, so privileged to be here. And I just thank David for this space, but we're only able to be in it thanks to our digital literacy to some extent or another.
Thank you very much. Several of you are writing in the chat about this. Really, really important. Ibrahim Inusa, where are you physically, Ibrahim? I know you're on this call. Are you hearing me, Ibrahim? Can you unmute? Not sure you can. Okay, if you can, and if you come unmuted in the next couple of seconds, that'd be great, but I can't see you. Ibrahim Inusa is saying, what on earth are we going to do into dealing with dealing with COVID in developing countries where the health system cannot provide the levels of healthcare that are needed? So we've been talking about the digital divide. Now we're talking about the divide in access to healthcare. Kathy Matthews from Canada saying, any progress on COVID-19 treatments? Lots of exciting possibilities, Kathy. What were you thinking about in particular? Over to you.
Thank you very much, David. I don't have any particular thoughts, just a scan of anything you're seeing that is encouraging. And just a side note that Toronto's voting today on mandatory wearing of masks in indoor public spaces.
Toronto, mandatory masks. Very delighted to hear it. People keep asking me, do I advocate mandatory mask wearing? I never like telling governments what to do. If I was in charge, I would absolutely require it. I think it's so important. Very glad to hear that, Kathy. Look, we don't have new antivirals yet. There are still some hopes for remdesivir and one or two other candidates. In terms of dealing with the host reaction, dexamethasone seems to work in people who've got really severe host response to COVID with cytokine storm. And there are one or two other approaches as well, but I have to tell you, that's it. We do not, unfortunately, have a therapy that looks like being widely available. There are still some hopes that one or two, what we call off-patent therapies might turn out to be useful. One in particular, dealing with the system, what we call the ACE system in the receptors in the respiratory system. Because we just have to keep hoping and watching to see whether there are any new prospects. Another question, WHO is talking about an infodemic of bad or misinformation. What about misinformation and conspiracy theories? Just want to say one thing to everybody. Why do we do these online briefings? Because we think it's right that people with the privilege of somebody like myself to be experienced in public health, to have worked on pandemics, as you just heard from Loy, and to be working on COVID, we think it's right that people like myself should be sharing what we know in an open manner, in an accountable manner, being recorded, being in the public domain. I want every single person who's working in public health to be helping others to make sense of this, and at the same time to expose some of the terrible challenges that are made visible through COVID, because it is these revealed challenges that in a way are the things we have to address. There are such inequities. There are such differences in access. There are such awful challenges being faced by poor people, as you heard from different people around the world. And it is our job to articulate these and to point it out to everybody. Thank you again for joining our briefing. Thank you for being part of the effort to spread what we know about this situation. And please stay engaged. Several are saying in the chat that we need role models. And I'm saying to you, you are role models. Let's stop imagining that it's the bosses who are the leaders. We are all leaders. We all have the potential to help others. And as I do say occasionally to friends, don't wait for somebody to ask you to lead. The call never comes. Just take it on and do it as best you can. And you'll find that opportunities go on presenting themselves. And you don't have to ask yourself whether you're doing any good. You just do it. And if you believe that you're doing good, in my judgment, it's likely you are doing good. I'd love Chris of Thinking the Unthinkable, not now, but perhaps next time if he joins, to give his view on how the new leadership is going to emerge. I know I give you notice, Chris, that next time I see you, I'm going to ask you to talk. He says yes. And then finally, Chris Lara, another Chris, I just want to say, as I'm looking at you, you inspire me with your leadership, Chris. I can't look at you and your picture and look into your eyes. So I'm looking to the camera, I'm talking to you, Chris. Thank you for your leadership on global health diplomacy at Duke University. I've seen so much evidence that you've been listened to by your colleagues, and it's so important. And when you link together COVID and Black Lives Matter, as you did so powerfully the other day, you really, really had an impact. Thank you for that. Now to Chris Shipton, just give us your, let's see if we can get your screen up for everybody to see. Here it is, coming into focus. Beauty. Terry Jackson, is there a Q&A, please? That's okay, is it? Fine, that's finished. We're now at 6:03 here. We have to stop now, but just have a look at Chris's picture as we move out, and just keep coming on the calls. We will take a bit of a break later in July. We'll tell you in advance. We're going to take a bit of time off, but just for the time being, please keep joining these calls twice a week, and know that we will continue to try to level with you and to give you an opportunity to talk. We've got 3 more briefings in this series left. So that's a briefing on Thursday this week, a briefing next Tuesday, and a briefing next Thursday. And then we're going to take a break and reassess.